Hi, everybody. We are a little hesitant to start because I'd like to see a couple more members of our committee show up. I see Donna Raftery from CB2 is with us. Oh, and Susan Kent, our chair.
Can they hear us?
Let's see. I can't.
They can. Okay, you can.
Okay, great.
Great. Thank you.
Just checking. I am muted. Redo. Am I still muted? Can you? No. Okay, Wayne, you can hear me, right?
I can hear you. You are not muted.
Okay, excellent.
Your mute button looks like it's on, but you're not.
All right, I'm going to go to my Zoom. This is a little confusing for me and I'm not like technically super adept, but I think I'll get there. I wanted to see the participants. Oh, we have 6 attendees. That's better than 0. Okay, can I see the sign-in sheet? So Keen is here. We'll start with attendance. Okay, let's do this. Welcome everybody to the October meeting of the Human Services Committee of Community Board 2. Our agenda tonight is primarily a conversation with people at Lenox Health Greenwich Village. Most of you, well, I think everyone on this call probably knows that Lenox Health Greenwich Village is a freestanding emergency department that is part of the Lenox Hill system. Wayne, correct me when I'm wrong.
Yes.
This neighborhood used to have a full service hospital, St. Vincent's, that was here since the 19th century. It closed about, I don't know, 10 years ago or something like that. And in its place, we have this emergency department, and it's good to have people from LHGV, which is how we'll refer to it, Lenox Health Greenwich Village, come in on occasion. And we know that LHGV has new leadership, so that's great.
And we have a whole slew of services, including the emergency room, but we'll talk about that in our presentation.
Great. And you also have a whole slew of staff here tonight, which is really very wonderful. Now, before we start, I've agreed for new business, I'm going to do something a little bit different. There's someone here who wants to talk about a subject that is not on our agenda. Normally that would be under new business and we would do that at the end of the meeting, but I prefer to do that at the beginning of the meeting. So I'm going to ask Adina, why don't you come up here and that way you can address all of us. I'm going to give you 3 minutes to talk, if that's okay. Is that okay? Okay. And if we then have questions, we'll, but I'd like you to, if you can, identify yourself, why you're here, and the subject you want to discuss, and then discuss it. Okay, I'm going to put the timer right like that. Okay.
Great. Thank you so much. I last used timers or was under timers back in when I was litigating, doing appeals in the 1980s, and we had buttons that went up, red buttons.
Well, they move fast, so I recommend.
Okay. So not to waste any more of my time, I'm Adina Schwartz. I've lived in this district for this community board since 1981. I'm a City of New York retiree. I taught at John Jay College of Criminal Justice for how many years? 23 years. Okay. Now, I'm here tonight to present the resolution, and I have, did anyone want?
And I'll share them with you later on, you guys.
After I talk, a resolution to preserve the rights, the entitlement that city retirees, people who've retired from city agencies, have enjoyed really since 1967 for a really long time, to the city reimbursing the premiums for traditional Medicare and providing them with Medicare plans. And we still have that, but it's been a hard struggle for over 2 years because Mayor Adams wants to force us all into a private Medicare Advantage plan, which many of you know, Medicare Advantage plans are often called Medicare disadvantaged plans because they narrow the network of providers who one can see dramatically from what one gets under traditional Medicare. And they also impose much more onerous and extensive prior approval plans. And we're basically asking you to support this community board, to support the bill that Congress Council Member Barone of Brooklyn and 16 other council people have put forward to preserve traditional Medicare and Medigap. And I should say, I guess in concluding, this is important for 250,000 city retirees and their dependents. It's important for a workforce that's extremely diverse and includes mostly lower income people. It includes first responders, many of whom were severely.
Sorry, I'll give you a couple more minutes to wrap up. I have some questions if you're open to those.
Sure.
I guess one of the first questions is, do you guys have a union? Do you have union representation?
No, an interesting feature is you are not a union member once you retire. Now, PSC CUNY, to which I belong, is the exception. You are a member. I don't know if we have full voting rights. I don't believe so. The teachers union, the UFT, people are members, but a retiree gets 1/10 of the vote of an active union member, but otherwise people are not union members.
And who then represents you in lobbying your elected officials? Who's
Well,
doing that?
Ironic thing is, even though we are not union members and have been told by our unions that we are not in terms of grievances, et cetera, the unions, the municipal committee, MLC, the Municipal Labor Committee that represents all the unions of the city, negotiates our health benefits.
Okay. Does anyone have another question?
Yeah, just thank you for coming. Are you here on behalf of a group of people? Are you here just as yourself, or are you representing?
Well, let's see. I was
Are you formally representing a bigger group?
I am not formally representing a different group. I've been in this association of various groups, and I think really there are various groups involved in this. The biggest group that has really fueled the litigation that has held this off is the NYC Organization of Public Service Retirees.
Mm-hmm.
Okay, thank you. Anyone else have any questions? Keen?
Yeah, well, I mean, obviously, you have one side of this. I wonder if what the idea is that Mayor Adams is trying to save a lot of money. Is that what's going on? Or is it somehow because he lives? Or, but what's happening
What
here?
prompted? What prompted?
Timeline as well. You said,
Mayor, oh, I'm sorry.
no, similarly, like in the history of it, you said 2 years ago, this changed.
About 2 years ago, when Mayor Adams came in, actually, this was proposed by de Blasio towards the end of his organization. Candidate Adams opposed it because he said he knew what he'd been promised when he was a police officer upon retirement. And this, quote unquote, was a bait and switch, promising him traditional Medicare and Medigap and giving him a private plan that would be inferior. Now, once candidate Adams became Mayor Adams, he switched. He claimed it would save the city $600,000. That's been debated. And also there have been claims that rather widely accepted that even if the savings are true, the city is having a lot of trouble now attracting new employees, and that people will be deterred by knowing this is a city whose representations you can't trust. You're promising one thing when you're hired and throughout your career, and boom, you're in a nursing home, you're in an assisted living place, and all of a sudden, you can't stay in that assisted living place because they insist on traditional Medicare and Medigap. The city doesn't provide it any longer. You don't have the money.
Thank you. Any other questions from the Zoom? I don't see any hands up. Thank you very much.
Thank you very much for letting me and for making the hours so convenient. I had assumed that if I spoke, it would be at 9:30 or so.
For one
welcome
person,
to
it's like
stay.
when you're on the shopping line at the supermarket, like just have a carton of it. Just go ahead, you know. If anyone would like copies of the
Thank you.
resolution, I can share them.
I remember you from TS3 days.
Sure, we can share it tonight, yeah. I also am remiss because I did not start the meeting with introductions. This is how we start. I'm Susanna Aaron. I'm the chair of the Service Committee. Is that Adina's sweater? Oh, yeah. Oh, good for you. No, you're good. Dean,
Yes.
will you introduce yourself?
Yes. I am Dean Berger. I'm a member of this committee.
Great. I'm just gonna sign initial for you. Ryder,
I'm Ryder Kessler. I'm also a member of the committee.
great. Is Akila Asqui on the call? Akila, can you? I don't see her. Akila, if you're there, you should raise your hand or unmute yourself. Okay, I don't see you and did not know you were not coming, so
Probably
no.
gonna rush in 2 minutes.
What?
She's gonna come here in 2 minutes.
Who? She will, oh, she may, yeah, right. Ritu. Yeah, online.
Present.
So, can you, great, that's fine. So remote quorum, is that right? I say remote quorum for her? Or
I
remote-
don't know whether she's remote.
Are you, do you have a disability? Is there a reason that you're not here tonight?
I did not see a location in the correspondence, and so I thought it was over Zoom. I
Oh,
apologize.
okay, okay, I will,
You know, technically,
I think actually is not as a quorum.
does not, doesn't count.
Okay, I'm gonna put you here. Just for the record, for the future, we always will be meeting in here unless you hear otherwise. Wayne Kwadler is on our committee, but tonight is recusing himself from the discussion because he is, why don't you introduce yourself?
I'm Wayne Kwadler. I'm usually a member of the committee, but I'm employed by Northwell Health and Lenox Health Greenwich Village. So I'll be representing them this evening and not as a community member.
Thank you. I know that Zachary Kazaz is not able to be here, that he's absent without notice. Ivy?
So I'm a member here, Ivy Kwan Arce. I also chair the arts. I have the absent thing.
Right, okay,
Yeah.
great. So you are part of our quorum. Juan Osorio is a new, thank you, Ivy, sorry. Did I step on you? And Juan Osorio is a new committee member, but I don't think he's here because I just learned about his joining our committee now, so, all right. And Rachel Yarmolinsky. Oh, she cannot be here this week. She's our public member. Okay, so she doesn't count. Okay, so we have 1, 2, 3, 4 people.
5 included. Ivy, 4 of us.
5, right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I guess we're supposed to have 6 for a quorum.
Wayne counts against quorum even though he's recusing himself.
Oh, okay, yeah. Okay,
Did it.
we have a quorum. All right, so, yeah.
Actually, technically, I don't think that counts. I think you have to be here in person, isn't that right?
Oh, Wayne.
Oh.
no.
Oh,
Yes, well,
unless he's been.
you know what?
Unless you have a special, unless you have a disability that's been,
Very good point. No, he recused himself. All right,
but
Maybe we didn't.
we can still pass resolutions, you know. I mean,
I think we're still, yeah, I don't quite understand the role of the quorum or not the quorum, but I'm not
we
the
don't, we do not,
parliamentarian.
we do not, according to the bylaws, we do
Okay.
not have a quorum.
Okay, remote, not quorum. Okay, Wayne. All right, let's get to the matter at hand. We have some guests tonight who are some NYU undergraduate students. This is a requirement for their course on economic development. I don't know how long they'll last, but we'll see. All right. Wayne, can everyone from Lenox Health Greenwich Village, can you guys introduce yourselves? I don't know, Wayne, if you want to sort of take the lead and toss it to people or how you'd like to do
Sure,
that.
I'll do that. I'll be happy to do that. So again, I'm Wayne Quadler. I'm the Director of Community Relations at Lenox Health Greenwich Village. Tracy?
Hi, everybody. I'm Tracy Firetag. I'm the Deputy Executive Director at Lenox Health Greenwich Village.
Dr. Woods?
Wait, clarify that for us, Wayne, because you said that your title is Executive Director, but actually you're the Director of the center. Is that right?
That's correct.
Thank you, and welcome to LH. Welcome to Greenwich Village.
Thank you. Thank you.
Dr. Woods?
Hi, everybody. My name is Dr. Tucker Woods. I'm the Associate Medical Director here at Lenox Health Greenwich Village, and I'm also the ED Chairman. Thanks for having us tonight.
And Gillian?
Hi, everyone. My name is Gillian Mangan. I'm the Manager of Operations for the Emergency Department at Lenox Health Greenwich Village. Thank you for having us.
David Seligman?
Good evening. I'm David Seligman. I serve as the Deputy Regional Executive Director for Northwest Western Region, which includes all of our sites in Manhattan. I appreciate you having us tonight. Thank you.
Dr. Dunham?
Yeah, hi, I'm Dan Dunham, Chair of Medicine at Lenox Health Greenwich Village, and thanks for allowing us to participate.
Dr. Kwan?
Hi, I'm Dr. Tak Kwan. I'm the Chief Cardiology in Lenox Health Greenwich Village. Can you hear me?
Yep.
Yeah, we can hear you great.
And Dr. Berkowitz?
Hey, good evening. John Berkowitz. I'm the Medical Director for EMS Transfer and Emergency Telehealth for Northwell, and thanks for having us here.
Thanks for being here. And I want to thank all of you, by the way, for making the time tonight. There's a huge showing from LHGV, and I know that, you know, everyone else has cocktails could be consuming right now. I know that you will try to be efficient with your time. I know that you have a presentation you wanted to make, so why don't we start with that, and then we'll save our questions.
Great. So I'll start off. Again, I'm Wayne Quadler, Director of Community Relations at Lenox Health Greenwich Village. We're also, as Susanna said, we're also known as LHGV, and we're a part of the Western region of Northwell Health, a member of the Northwell Health family, and our sister hospital uptown is Lenox Hill Hospital.
I'm going to interrupt you because I just noticed that there's an attendee with her hand up, Susan Herzog. Can you, how can she be much? We're not taking questions at this time, Susan, but if there's something quick you needed to say, can you just tell me what that is? So, Susan Herzog at the top of the list. Are you there?
Can you hear me?
I
can. Actually, I raised my hand earlier when my elderly colleague was speaking about the resolution. I was not able to attend with her because I'm caring for my mom, who's 106. Okay. But so I would have, if I had been there, I would have joined her in asking you, the committee and then the board to support the resolution that would support the city council in protecting several hundred thousand of our municipal retirees from being forced into for-profit managed care. And so I know I said she gave you a copy of a proposed resolution, and we were hoping that you would put it on the agenda for next month's meeting.
Thank you very much. That's great. Thank you very much for your comments.
That's what.
Okie doke. Sorry, now we will resume our normally scheduled program. Sorry about that. And sorry, Susan, for not seeing your hand earlier. Go ahead.
So we're going to talk a little bit about our leadership, our programs, our patient experience, our community impact, our resources, our vision, and our story.
Okay.
And at Northwell Health, we always start with a patient story, a patient who has written in. The doctor that treated me was wonderful. I'm from out of town, which added stress to the accident. Her top-notch communication skills put me at ease when I received care, especially stitches. The doctor who removed my stitches commented on how good a job she did. And if all doctors were like her, medical treatment would be much less stressful. And let me turn it over to Tracy Firetag, who's the head of our building at Lenox Health Greenwich Village.
Thanks, Wayne. And thank you so much, Susanna. It's really a pleasure to be here, and I'm happy to meet you all virtually. Looking forward to meeting you in person at some time in the future. So just a little bit about myself. I spent 16 years actually with the New York Presbyterian system before I came to the Northwell Health System in 2011. I started at Lenox Hill Hospital. And then a couple of years later, I had the distinct pleasure of being part of the team that opened Lenox Health Greenwich Village in 2014. So it's probably the project that I'm most proud of participating at any point in my career. I left Lenox Health Greenwich Village in 2016 to do some other work around the organization. And then I came back in March of 2023 this year to lead the building and drive the growth and build some additional services in this community. So I'm looking forward to talking about our exciting plans that are lay ahead at a little bit later in this presentation. So we do have Dr. Woods here as well with us, and Dr. Woods and I and Wayne will go through the presentation together. But as you can see, you've already met some of our other team members who will be here with us after the presentation to answer any questions that you might have. So I'm going to pass it over to Dr. Woods to introduce himself more thoroughly now.
Hi, everybody. My name is Dr. Tucker Woods. Again, thank you for having me. Just a little bit about me. I'm board certified in emergency medicine, so I'm a ER doctor. I've been practicing emergency medicine for over 25 years, and I'm also board certified in addiction medicine, helping patients with addictions to drugs, alcohol, tobacco. Like I said, I've been practicing emergency medicine for over 25 years, and I've been in hospital leadership, hospital administration for about 20 plus years. But it's a pleasure being here tonight, and we've been looking forward to this presentation. So we're going to first just start off by talking about some of our programs. And as Susanna said earlier, so when St. Vincent's closed in 2010, it really did create a huge healthcare gap for the local community in this region, especially when it came to emergency care. So our journey really starts in 2014. So in 2014, the emergency department opened here at LHGV. So we just celebrated our 9-year anniversary. And then we've had growth throughout the years. In 2016, we opened up an imaging suite on our 5th floor. Then in 2017, we opened up a same-day surgery center on our 4th floor. And then we also opened up physician offices in 2017 on our 6th floor. And then I would also be remiss to not talk about the amazing services we provided during COVID. So on top of all the various COVID patients we took care of it in the emergency department, we literally took care of thousands. We also repurposed our operating room suites, and we created a COVID inpatient unit when we were really at a crunch for beds throughout New York City. We also created a COVID vaccine center during that time as well, but we're quite proud of our COVID response. So where do our patients come from? So this is a heat map that shows where patients come from when they come to our emergency department. And the darker the region, that's where we tend to have more patients. So as you can imagine, the bulk of our patients come from Chelsea, Greenwich Village, West Village, Herald Square. But also our catchment area is even beyond New York City. It's northern Manhattan, it's Brooklyn, it's Queens. We don't have Jersey on here shaded, but we also get patients from Hudson County, the Jersey City area.
Can I ask a question about that? I'm going to guess that those are not people driving to Greenwich Village when they get an injury in the middle of Brooklyn. They're either working here or they're here for the evening. They're visiting. Is that a fair assumption?
Yeah, the ones from New Jersey tend to be folks that are employed in New York City but live in New Jersey. Okay. But you would be surprised though, even from Queens, a lot of the I've taken care of several patients from Queens, and they tell me I live in Queens, but I've heard such good things about your ER. I didn't mind taking the 30-minute subway ride.
Wow, okay, kudos. That's nice.
So how busy are we? So we take care of a lot of patients each year. Before COVID, we were averaging about 108 patients per day, or 38,000 plus patients per year. And we're slowly recovering that ground we lost due to COVID. So right now, we're almost at our pre-COVID levels. Right now, we're averaging 107 patients per day. And then, as Susanna mentioned earlier, we're not yet a full-service hospital. So this also breaks down our admission. So if a patient requires inpatient care, they will be transferred. And about 8% of our patients are transferred when admission is required. So again, like I mentioned earlier, most of our patients are treated and released, but if you do need inpatient care, we will transfer you to a hospital for that definitive care. And I'd like to spend a lot of time on this slide because there are many factors at play when a patient does need to be transferred. So I'm just going to go over the various factors. And when it comes to transfers, the doctor and the patient have the same goal. They're fully aligned. The doctor wants to transfer that patient as soon as humanly possible, and the patient also would like to get to that definitive destination as soon as possible. So what are the various factors at play? So the biggest driver by far is the diagnosis. So there are disease-specific conditions that have to go to specialty centers. So if you're a burn patient, for example, that would have to get transferred to a burn center. We do get a decent amount of trauma, so trauma patients would have to get transferred to a trauma center. Stroke patients get transferred to stroke center. So if it's a disease-specific condition, the hospital you get transferred to will be transferred based on those diagnoses. Patient condition and acuity is a big factor of it. So if there's a situation where a patient has a diagnosis where minutes matter, we do something called a tier 1 transfer. It's lights and sirens, and we have specific workflows in place to make sure those do go as fast as humanly possible. Bed availability is one of the most important rate limiting steps with our transfers, and it's on the top row for a reason, but I'm going to come back to it at the end. Patient consent and preference is very important as well. Legally, the transfer laws require that we have patient consent whenever we do a transfer, and whenever possible, we always try to find out if the patient has a preference when it comes to admission. Decision-making capacity is a big factor. So if a patient is in a coma, we have to act on their behalf, or if they're have a behavioral health issue or suicidal ideation, sometimes there's limited decision-making capacities, or if we're dealing with a minor and we can't reach the parent. Is the patient contagious? So infectious disease is a big factor. If a patient has COVID or has tuberculosis or this or that, a contagious condition. Just to give an example, if a patient has asthma, there may be 10 available beds at hospital A, but if it's asthma with COVID, those patients require an isolation room, and those are in short supply, so that can become a big issue at times. Special populations plays a role. Is this a maternity patient? Is this a pediatric patient? Coordination with the primary care physician also plays an important role. Many of our patients do have primary care physicians, and they'll provide valuable information. And if they have admitting privileges or have a hospital preference, we really rely on that primary care physician. Another factor, if we have an accepting physician, is does the patient first need more stabilizing care or additional tests before we transfer? Sometimes a hospital might say, we really want you to give this medication or get an additional CAT scan before sending that patient over to us. One of the things that's legally required when we do transfer a patient is having an accepting physician. We cannot initiate a transfer unless we have an accepting physician. And I'll talk about how that works. And then also, when we do have an accepting physician, sometimes we also have to have a unit-based physician acceptance. So let's say the neurosurgeon is the accepting physician, but the patient's going to go to the ICU. The ICU physician might have the final say, depending if he or she has beds or doesn't have beds in their ICU. And there are a couple In addition to those requirements, those sign-offs by those physicians, there's a couple hospitals in Manhattan that also require CMO approval. So Bellevue comes to mind with the exception of transfers, and NYU also has that additional layer of approval when transferring. Another factor at play when we transfer patients are equipment considerations. So sometimes patients will need special equipment when we transfer them. And then, as you can imagine, as New Yorkers, traffic conditions is really a big factor, believe it or not. So when we have a patient with a heart attack, they say time is muscle or cardiac muscle. And the goal is to administer life-saving treatment within 60 minutes from when the chest pain started. We will not transfer, for example, to Lenox Hill during the hours of 6 a.m. to 9 p.m. if a patient has a heart attack. We learned early on we're not going to meet that 60-minute treatment goal. And then nurse-to-nurse report is also a critical factor. So once we do have all those accepting physicians and acceptance by the hospital, there's nurse-to-nurse report. And then we just have to determine if the patient goes ER to ER or ER to floor. So I want to go back to bed availability. So bed availability is probably the biggest rate limiting step. And sometimes I'll even say to my colleagues that the doctor and the nurse, they're not the VIP. It's actually that bed. We really need a bed available. And I think we learned during COVID, there's oftentimes a supply and demand mismatch where New York City has more patients than they have beds. And even during the course of the last 2 decades, New York as a state has lost 20,000 inpatient beds because of the various hospital closures throughout the years. Next slide, Gilly. So you saw from the previous slide all the moving parts when we need to transfer. It's a really big process. And so how do we do it? So Northwell has spent made a lot of investment into what's called the centralized transfer center. So when we do want to initiate a transfer through the centralized transfer center, one phone call essentially does it all. So if I'm transferring a patient to NYU or to Mount Sinai or to the Lenox Hill, I call the centralized transfer center. I give the patient, one of the first questions I ask is if it's a lights and sirens or a tier 1 transfer. It's one unique thing about Northwell that I haven't seen other systems do. If it is a tier 1 transfer or critical patient where minutes matter, they have this auto launch feature. So even though I'm still describing the patient and I might have another 5 minutes to give the details, they've already dispatched the ambulance and it's on our way to the emergency department. And they handle everything. They'll call the receiving hospital. They'll get the specialists on the line. I've had 4 or 5-way conversations through the transfer center where I'm speaking to the neurologist and I've got the cardiologist on the line and I've got the intensivist. So it really takes a village. And this photo is amazing. It almost looks like something out of NASA, but they're really the wind beneath our wings, if you will, when we initiate transfers. So I'm just gonna go over like some of just one workflow as an example. I'm sorry, did somebody say something?
No, go ahead.
So I'm just gonna describe, in our emergency department, we have this thing, it's called the everything book. So we came up with all the different scenarios, all the different diagnoses, and we wanted to see if we could shave as much time as humanly possible. And this is just a simple example. Is this a hypercritical patient? So hypercritical means it's somebody who came in cardiac arrest. We were administering CPR and we have the pulse back and now we need to transfer them. So this would initiate our hypercritical workflow. And you can kind of see how it works. So do you have a hypercritical patient? Yes. Any suspicion for trauma? If it's yes, we call the transfer center. They go to the trauma center, Bellevue. If there's no trauma, we call the transfer center and then we transfer them to Beth Israel. That's physically, it's the closest hospital we have. So they're part of our hypercritical workflow. And if you go into the details, we did whatever we can to shave time. So you can see in that lower box, grab and go, no waiting for charting. During transport, hold off all of the non-life sustaining trips. So these workflows are very helpful when minutes matter. Next slide, please. So this next slide, it just goes over the total length of stay data for our patients when they do get transferred to other hospitals. And And in most months, patients go into the Northwell facilities. They tend to have a shorter length of stay than if they're being transferred to a non-Northwell facility. In the dark green are patients that go to Lenox Hill Hospital, and then the lighter shades would be non-Northwell facilities.
Wait, can you clarify? Sorry, can you go back to that slide?
Sure.
So you're saying that length of stay in the hospital they're transferred to?
So this is door
length of
to.
stay at HGV. I see. Okay, so I see. Sorry.
It's basically like door to departure time, if you will.
Got it.
Thank you. So on this slide, I just want to talk a little bit about data and quality. So the transfer center, they have this, they have a dedicated data scientist, they have a senior analyst, and they have a quality coordinator. And the centralized transfer center has this custom-built system for continuous quality improvement of the transfer process. And we really rely on them for their services. One interesting fact I learned through the data scientists is when we're trying to transfer to a non-Northwell hospital, we actually get denied 34.5% of the time. When we transfer to Lenox Hill Hospital, their denial rate is 1.1%. So it's a pretty big gap. And then on the far right, you can see ring to clinical acceptance times, Northwell versus non-Northwell, and then clinical acceptance to facility acceptance. So they really tease us out by the minute.
So in other words, cases that are denied means that you call whatever, NYU, and they say, we don't have a bed. Or
correct. They'll say, exactly. They'll say no bed. Sometimes a hospital will say, we don't have that's not one of our patients, but more often than not, it's no bed. Or every now and then they'll say it doesn't meet our criteria for acceptance. But by and large, we will frequently get no bed. I'll just give an example. I was working a shift a few weeks ago, and I had a elderly lady with a hip fracture, and she said, I want to go to hospital A. I called hospital A, and the orthopedic surgeon said, I would love to take this patient, but we have no beds. And so I spoke to the patient. She goes, can you call hospital B? I called hospital B. Same story. The orthopedic surgeon said, I would love to take, but we have a bed crunch here. I really can't accept. So then I ended up going with our third option.
So let me ask you one question about that. And first of all, I should explain to people that one of the reasons we're talking so much about interfacility transfer is that that's an area of concern to some of us. And so we've asked LHGV to sort of concentrate on that, although this conversation is open to anything we want to talk about. I know my parents were just in the hospital. They went to NYU. They were in the emergency room for 24 hours before they got a room. Now, what happens if you are, you want to go to NYU, let's say, or whatever, you want to go to hospital A, and they don't have a bed now, but they might have a bed in 12 hours. What happens in this case?
We will give the patient that option. So it's a joint decision made with the patient, and we'll say they do expect to have a bed in 12 hours. Do you still want to wait for that bed, or do you want to come up with a second game plan? And in those scenarios, we let the patient decide.
Great, thank you.
Yep. Next slide, Gilly. Okay, so next I just wanted to, before I turn it over to Tracy, I just wanted to highlight a few awards and accreditations we're quite proud of. So we recently received our North Star 90 award celebration to recognize patient experience outcomes in both our emergency department and our surgery center. And these are awards that are in the 90th percentile nationally. So we're quite proud of that. And then in 2022, this is really prestigious, but we received the Lantern designation to recognize the nursing excellence in the emergency department. And then in 2023, this year, we actually received 2 accreditations. So we received what's called pain and addiction care in the emergency department. We have a core competency in treating patients with pain using alternatives to opioids. And then we also provide a high-level addiction care. And I really leaned on my background in addiction medicine. And as you all know, there's a terrible opioid epidemic going on in our country. So we're very proud of that. We're the first hospital in Manhattan to receive that award, along with Lenox Hill. And then lastly, earlier this year, we received primary stroke certification by the Joint Commission to designate our site as a center of excellence for stroke care. So that's another core competency we're quite proud of.
Congratulations for all of these. And all of these, to be specific, are LHGV or are they Northwell Health?
The PACE accreditation and the Lantern was LHGV and Lenox Hill, as well as the North Star 90 award. And the primary stroke certification was just LHGV. Lenox Hill actually has comprehensive stroke center designation.
I guess the Joint Commission, I know nothing about hospitals, but I know that the Joint Commission is an independent organization that evaluates hospitals. And I've noticed that LHGV is not evaluated as a separate entity from Lenox Hill. Is that correct? Who looks at LHGV as a separate entity, as a standalone entity? Does anyone?
Tracy, do you want me to take that, or did you want to take that?
I could take it. So Lenox Health Greenwich Village is on the operating certificate of Lenox Hill Hospital. So we're part of them. So when the Joint Commission comes to survey Lenox Hill Hospital, they also come to us at Lenox Health Greenwich Village. And we have another site in Manhattan as well, Manhattan Eye, Ear, and Throat Hospital, Meath on 64th Street. They go there as well. So there's
you guys are regarded together and not as one unit, not as separate entities.
Correct, but occasionally we can get our own certifications that aren't connected to Lenox Hill Hospital, but mostly we try to do things together.
I guess an area of concern for me over the years has been, let's say that the hospital on 77th Street is great and wonderful, but let's say that for whatever reasons, there's like roaches in the hallways downtown, or whatever. Your nurses are coming in drunk. I don't know, whatever it is. How would we know? I mean, we would only know by looking at the whole entity of Lenox Hill. And there's no real entity that separates this building and the function of this building and evaluates that. Is that correct? I mean, I guess it's just a part of the system of how it works.
Right. We do have with the Department of Health a separate facility ID number, a separate site, but in terms of the operating certificate and how we're surveyed, it is together. But we have our separate quality scores, we have our separate patient experience scores, all of that is separate. So you could probably find that those separations on some of our reviews.
Yeah, to piggyback on that, sorry. I'm curious, like what the data is that underlies the patient experience, like being in the 90th percentile plus of patient experience. Is that patient like scores that they've given you? And if so, I think we would be curious to know like the LHGV score versus the overall Lenox Hill score. That would be interesting for us to know. Are you performing above the whole system, or is there a differentiation?
So Dr. Woods could brag a little bit about how the emergency department does for in the system, but just in general, we compare ourselves to the country. And so when we say the North Star 90, it's that we're exceeding the 90th percentile nationwide for that reporting period. So like I said, we do track all of our patients get a survey when they leave the hospital, whether that's the emergency department or the surgery center. They fill out that survey and then we get the results of it separate for our site. And then we compare ourselves, like I said, sometimes we compare ourselves internally within the organization, just as a way we look at it. But for the most part, we're comparing ourselves to hospitals nationwide.
And Tracy, isn't it true that we do get audited by Joint Commission individually for several days? And if there were any things that we weren't good on, they would highlight that or cite that?
We would get cited, but it would be part of the overall Lenox Hill assessment.
Review, right, assessment. So what
I'm sorry, Susanna, can I just interrupt here?
Sure.
Is it possible for us to just get a copy of the patient survey, what questions are asked, in order for us to understand the metrics upon which Lenox Greenwich Village?
Yeah, definitely. We can provide all of the questions. When we talk about the one question that we look at the most when we're talking about our results is recommend the hospital. So It's always on a 5-point Likert system. Would you recommend the hospital? Strongly agree, neutral, disagree, strongly disagree.
Got it.
Standard net promoter. Yeah.
So what I'm understanding you say, though, in terms of this point that I keep harping on, which is the assessment and valuation, internal to the Northwell system, you guys collect data about the operational success and whatever sort of metrics on LHGV itself. To outsiders will see LHGV only as part of the larger unit. The breakdown in data exists. There's separate data for the 7th Avenue facility, but as in terms of the joint or anyone else who would be reporting out to the public, they will see it all as part of one system. Is that a fair understanding of that?
Yes.
Okay, good. All right, sorry. Let's see.
Next slide, Gilly.
Okay, great.
Turn it back over to Tracy.
Good. Thanks for that conversation. So Susanna, you actually queued a point up perfectly that I wanted to start with, is that we hear a lot in the community that we're a freestanding emergency room, or we're that, there's an emergency room here. And not enough people know about the other services that we have in the building. So we're excited to tell you about it. And we hope over the next year or so to make sure that the community is aware of other services that we have in addition to the emergency department. So Dr. Woods mentioned before, we do have an ambulatory surgery center. So this means that if you're going to have a surgical procedure, but you don't need to be in the hospital, it's same day surgery, you could have that surgery here in this building. So we have
Would
four.
that happen with an LH, would that happen, like, who would be the physician? Is it a staff physician, or is it your own physician using the facility, or is it part of a Northwell physician? Like, how does that work?
Yep. So we have both employed physicians that are employed by Northwell, and a lot of our Northwell physicians operate at multiple Northwell sites. And we also have voluntary physicians, which are physicians that have credentials at our site, but that aren't employed. And we have both. We're actually at our surgery center, 60% of the surgeons are Northwell employed surgeons and 40% are voluntary.
Wow.
So if you go to, let's say, an orthopedic surgeon and they have privileges at our site, you can come here.
Great.
So, yep, we have 4 very, very large modern operating rooms. They have obviously the most up-to-date technology since they're new. We also have 2 procedure rooms where we do colonoscopies, endoscopies, and minor pain procedures. And as we talked about already, our patient experience scores are very, very high. And the competition in ambulatory surgery centers is very difficult. So sometimes we could do, have a little bit of improvement and stay the same in our national ranking. And so it's very competitive. We're looking at it very closely and constantly coming up with new initiatives to try to improve on that patient experience. And, if you ever come here, it's a warm and gentle environment. And we understand that when you come in for a surgical procedure, it could be very stressful. And so we've created an environment that is calming. So
I have been in your emergency room, and it is a very calming environment.
Yeah,
yeah, it's just a feeling in the building, and it is also on the 5th floor imaging center and the 4th floor surgery center. It feels the same way all the way through the building, even more so, I think, on the other units.
So I have a question about the imaging center, for example. So let's say my parents have a doctor that is part of hospital system A, and they say, we want you to have a sonogram of your kidney or whatever it is. And, but hospital A is far away. Can they say, we'll write a prescription and we'll do it at LHGV?
100%. When the doctor writes the prescription, you can go anywhere you want. And most people will go where their insurance covers, but we take nearly every insurance. So yep, for imaging, you can come even if your physician is not associated or affiliated with Northwell.
And our board member, Donna Raftery, is chiming in. She also has been in the emergency room, and it was a very pleasant experience.
Can I just ask, do you participate in the information exchange with NYU Langone and Weill Cornell and New York Presbyterian and Mount Sinai?
Yeah, so the Health Information Exchange is a system, just for those that don't know, where a lot of our medical records data gets sort of like pulled through the air, and so does Presby and NYU and many other systems in this area, and it all goes into a centralized medical record. And you could, so if you come to the emergency department and you see Dr. Woods could pull up some of your information, but not everything. So I think it has like diagnoses and medications maybe, and Dr. Woods could speak better to this, but it might not have clinical notes in it. Is that correct, Dr. Woods?
Yeah, you're referring to my
The
chart
HIE.
by Epic. And so we are transitioning to the Epic electronic medical record April 5th of 2025. And it will actually be much easier to share information. But like Tracy said, we can get some limited information from sites that use a different medical record than ours. Correct?
Yeah. Well, I think that's a problem throughout the hospital systems, right? Like if you're at Mount Sinai, you can't really see the NYU records and so on and so forth.
Actually, you can.
Oh, okay. Yeah, my whatever, NYU, whatever.
Yeah, there's some limited information, but many systems are
right.
moving to Epic, and then there'll be easier sharing of information.
That's encouraging.
Yeah. So anyhow, we do take care of a lot of specialties in the surgery center. Some of our services that we offer are orthopedics, ENT, general surgery, neurospine, and plastics. And you can see on this slide the tremendous growth that we've had since we opened. We're projecting this year to have over 4,200 cases in the surgery center, and there's definitely room in the facility for continued growth. So we're expecting to grow even more next year.
A lot of surgeries.
So next up, we have our incredible imaging center. Again, it's really, really beautiful. Hopefully some of you have been there before. And again, just like the rest of the building, it has a calming environment. It's very soothing. And on this slide, you could see all of the imaging techniques that we offer. So X-ray, CAT scan, MRI, mammography, ultrasound, etc. So if your doctor orders any imaging, you should come try us out if you haven't yet.
Yeah.
And this is the growth in our imaging center. So again, lots and lots of growth, and we plan to continue to grow moving forward. And now I'm going to turn it back to Dr. Woods, but I'll be back shortly.
Thanks, Tracy. So next, I just want to talk a little bit about patient satisfaction, or what we refer to as patient experience. And patients, obviously, they have a lot of choices in New York City, and we do want them to choose us. And I just want to talk about some things that we're doing to improve the patient experience. So these are just two examples where we like to leverage technology to help improve patients' experiences. So on the right, one unique option patients can use for less serious emergencies is an online check-in option. And this way, our staff is expecting you, they can have a bed prepared. And then on the left is another new service we started to offer, and it's this real-time patient feedback option. So a lot of folks like scanning those QR codes. And so we have this label at every bedside, at every next to every stretcher. And if you scan that, there's a couple questions, and you can provide real-time feedback. And I would say 9 out of 10 times it's something very positive. However, a patient can also type in, my room is too cold, and we get that real time. And so then somebody will go to the room and they'll, deliver a blanket. And then on the next slide, this is my last patient experience slide. The first two couple of items are from our same-day surgery center. So we have these wonderful journey maps. So if you're going to our same-day surgery department and you're having a surgical procedure, or you're having a colonoscopy, these one-page journey maps, they actually tell the patient what to expect from the beginning, the middle, at the end. And then when the procedure is finished, we have these really nice discharge folders to make sure the patient understands everything after they're discharged from the hospital. Information about their medications, how to reach their doctor if an emergency. The last two bullet points are services offered by our emergency department. So we have these results business cards. So after the patient leaves, before they leave, we hand them this results card. And if patients do have questions later about their results, they can just call our results line, and they'll be connected to a physician, and we'll help them understand the results or if they had any questions. And then another service we offered that we started this year is called leadership patient rounding. So obviously the nurse and doctor will round on you when you're in the ER, but now we have leadership rounding on patients to check in on them to make sure everything's okay. So that could be me, it could be Tracy, it could be our nurse manager. It's almost similar to how a maitre d' at a restaurant might round on some of the customers at a finer restaurant. And our patients like that level of detail, and it shows that we really do care about the patient experience.
So when you say regular rounds, like what does regular mean? Is it daily, or do you do it like a couple of times a week?
So the leadership rounds are Monday through Friday, and we have a calendar of what leader is going to be rounding that day. And then in terms of clinical rounds, that's just, when you're seen by the doctor, you should be seen by your doctor in the beginning, the middle, and the end of your visit. And those are the clinical rounds, and that's something separate from the leadership rounds.
Thanks.
And next, I'm going to turn it back over to Wayne.
So now I'm going to talk a little bit about our community impact. Susanna, this is our community. This is something you might actually want to use when you do your statements of needs next year.
Yeah.
It shows some of the health statistics for the village versus Manhattan that our departments have pulled. And you can see Greenwich Village is a little bit healthier and more well off than the rest of Manhattan.
Okay, great. Hey, and will you be able to share this PowerPoint
Sure.
with me?
Yeah, absolutely. And these are some of our other community initiatives. We do flu shots at senior centers. We do free flu shots at LHGV. We do blood pressure screenings. We go to health fairs and street fairs. We have partnerships with the LGBT Center, with Greenwich House, with Hudson Guild. And we do lots of different programming in the community itself.
Right.
And now Tracy's going to talk about future plans.
Oh, okay, great. Here, I thought my computer was going to go out. So, I'm glad we've had the opportunity to kind of catch you up on the last 9 years, what we've been doing and how we've been growing, but what does our future bring, and what more do we have to offer the community? So, first, I want to talk a little bit about our outpatient offices. So these are physician practices. When we opened in 2014, we really didn't even have any physician practices south of 36th Street. And we've been spending a lot of time, effort, investment in building this up. So this is our current landscape. As of today, we have 13 sites in this area, and we cover over 25 different medical specialties, so primary care and all of the subspecialty services that you see on the slide. So we're really excited about the growth. We have plans for continued growth, and we just hope to keep increasing the number of offices that we have and the specialties that we offer downtown.
Right.
Our ultimate goal is to be the neighborhood hospital of choice and expand care options for our community. And so what are we doing in order to meet that goal? So we have what we're calling the Greenwich Village Expansion Project. We're extremely excited about it. It includes the addition of a small inpatient unit, a cardiac cath lab, and advanced emergency care. We are imminently starting construction on this project. We've received approvals from the state and from the city to start construction. So we'll be starting in November, December. We'll work through a lot of workflows, a lot of program development over the next year and a half. And then we're slated to open these new services together at the same time in either first or second quarter of 2025. It's really exciting. These are really exciting services. We've talked a lot today about transfers. It's going to be a very small inpatient unit, only 8 inpatient beds, but it will help reduce some of the transfers that we have. Like Dr. Woods was saying before, recently I was rounding and I met an elderly couple, and the husband was the patient, and I said, how is everything going? How is your experience so far? And she says, well, it's great when we're here, but, every time he gets admitted, he goes to Lenox Hill Hospital, and it's really far, and it costs us a lot of money for me to go visit him, and I'm never sure if I should go up and visit him or not. And so it made me feel really good that we were working on this project to have an inpatient unit, because we will be able to allow some people to stay in their community. Now, the criteria will be, there'll be inclusion criteria, of course, to be able to stay, but it's a step in that direction, and we're really excited about it. And in addition, we have some people on the call that will be able to talk to some of the cardiac cath lab services as well. And the rooms on the inpatient unit, they're private, they're large, and of course they have that beautiful view of downtown, down 7th Avenue, and the Freedom Tower. So it's really nice, something I'm really excited about. And we'll answer questions about this shortly if you have any, but just to finish off, I'm going to pass it back to Dr. Woods to tell us a little bit about some of our Greenwich Village stories.
Thanks, Tracy. So I'm just gonna, lastly, I just want to highlight a couple of things that we're quite proud of. The first story I wanted to highlight was that we were actually featured on Netflix for 2 years in a row. So first on the show Lenox Hill, and then on Emergency NYC. And it was really remarkable because our staff allowed themselves to be followed around for several months by these film crews, and they really captured what we do every day. These are not actors, these are real nurses, real paramedics, real doctors. And I'll be honest, I had to grab a box of tissues for a few episodes because it truly captures the humanity of medicine that we deliver. And I was so proud. I was texting all my friends, you have to watch this. It's really amazing. And so, and on the far left is Dr. Martha Macri. She works right here at Lenox Health Greenwich Village. If you ever come on an overnight shift, you'll see Dr. Macri. She's a nocturnist. She works overnights. And on the next slide, another story I wanted to highlight is sort of the innovative ways we at Northwell can help outside, not just in New York, not just in the nation, but other countries. So since the start of the Russia-Ukraine conflict, about 200 healthcare facilities in Ukraine were destroyed. So over the past 1.5 years, our Center for Global Health played an active role in supporting frontline Ukrainian healthcare workers. And we've provided real-time telehealth support in trauma surgery, neurosurgery, critical care, along with these doctor-to-doctor consults. And earlier when I showed you the transfer center that looks like Nassau, so our transfer center played a key role in setting up all of this. We also delivered over $1.5 million in medical supplies to Ukraine, and then we're also donating 12 ambulances. And when President Zelensky flew to the New York for the United Nations meeting, he actually did fly to take a helicopter over to Staten Island University Hospital, which is part of Northwell, to given a distinction award for all the efforts and medical care we have been providing over in Ukraine. So we're really proud of that. Next slide. So we're really proud of what we're doing here in Manhattan, and we're trying to get the word out. So we have various health campaigns that are in play right now. And I'll just give an example. So last week I was taking care of this 94-year-old gentleman, and he was here with his son, and the son said to me, "Your ER is so nice." He goes, "It's so zen, Dr. Woods." He goes, "I don't want to tell any of my friends about it because this is a nice secret. I don't want others to know." But the reality is, I was very happy to hear that. But the reality is we are trying to get the word out. So I hope some of our health campaigns will make an impact. Next slide, Gilly. And so basically, we are here if you need us. This concludes our presentation. If you ever do want to reach me or Tracy, we have both of our emails on here. And obviously, if you spoke to Wayne, he can get in touch with us as well. But please feel free to write down our email. If you do want to know more about our services or about the emergency department check-in system I spoke of earlier, we have QR codes for that as well. And then lastly, just one PSA, one public service announcement. We are seeing a lot of positive flu cases right now here at Lenox Health Greenwich Village. So I do recommend everybody get their flu shot, but we're starting to see those flu cases creep up. So remember to get your flu shot, guys. And that's it from me.
Thank you. I need that reminder every year. Thanks a lot. And thanks for all the work that I'm sure you put into this presentation. I have a bunch of questions and I'm sure others do as well. I'm just going to kick it off. Can you just, I have a question about staffing. So I mean, I've been to many places where I'm treated by a doctor, or I'm treated by a physician's assistant, or I'm treated by a licensed nurse practitioner. What is the staffing in the ER?
Sure. So during peak hours, we have 3 attending physicians working, and then we have 2 PAs. Some emergency departments and other systems, other parts of the country will actually have more than 50% PAs, but we have a stronger physician presence. The PAs are critical, though. They're very helpful. We work as a team together, but we have a higher physician ratio over PAs compared to some other healthcare systems.
Are the physicians specialized in emergency medicine? Is that, or are they from other fields?
So all of our physicians are board certified in emergency medicine. That's something that we require. That's the highest level of certification. And I almost say we have the Navy SEALs of physicians. So you can't work in our emergency department until you've had several years of experience as an attending physician. And then a lot of our ER physicians went that extra step and became board certified in other specialties as well. So for example, I'm also board certified in addiction medicine. We have several physicians that are also board certified in ultrasonography, or emergency ultrasound. We have 2 doctors that have a second board certification in pediatrics. I have another physician that's board certified in international medicine. So a lot of our physicians actually are double board certified, which is pretty outstanding in my opinion.
And how many shifts do they each work a week? Do they work 5, 8 hour shifts?
If you're full-time, you work on average 12 or 13 shifts a month. We have some part-time physicians where they might be 80% full-time, and so they would do about 10 shifts a month. And then we have some physicians that are 50% full-time or 50% part-time. But if you're full-time, you do about 12 or 13 shifts a month.
And so you mentioned peak hours. What are peak hours? When are those?
Peak hours would be from 4 p.m. to midnight. On Fridays and Saturdays, I would say 4 p.m. to 2 a.m.
Okay. And so what is the staffing when it's off-peak hours?
Off-peak hours, so we drop down to 1 physician and 1 PA after midnight, Monday through Thursday, or I should say Sunday through Thursday. And then on Friday overnights and Saturday overnights, we drop down to 1 doctor, 1 PA from 2 a.m. To 10 a.m. the next morning.
Okay, great.
And we have very complex algorithms that look at the arrivals per hour, and we can tweak that staffing as needed. But I would say we're better staffed than most of the emergency departments in the city.
I'm just going to call out names because it's a small group. So Ritu.
Hi. So I just wanted to provide a little bit of feedback. I think the facility is wonderful. I think the staffing, 99% are terrific. The responsiveness and the communication is wonderful. I do want to point out, however, that, and this is not recent, this is probably feedback from 6 to 12 months ago, but on frequent ER visits, there was a very strong reluctance to allow transfers to non-Northwell hospitals. And that is just, that was problematic for us. I had to deal with an elderly mother whose physicians were all located at NYU. And between the travel to the Upper East Side, as well as the lack of communication, if she were to go and be admitted to Lenox Hill, we really wanted the NYU ER, despite whatever wait time we'd have to go through in their ED. And so I think that is something that has been unaddressed. And it would be good to have that as a point of conversation with your staff, particularly your overnight staff.
Rita, can you explain what you mean by reluctance? Can you just be more specific about that?
Yeah, they didn't want to do it. And so fortunately, I have someone that I know that is a physician at LHGV, and I was able to text her and elicit her help. And so this happened on, a half a dozen times. And that's how we managed to get it done. But there was a strong, not a reluctance. They just wouldn't do it.
But when you said they wouldn't do it, they wouldn't execute the transfer?
They wouldn't coordinate the transfer with NYU.
I see, okay. I'm going to throw in a similar experience because then we can ask you guys to address both of these. This is actually one of the reasons we're having this meeting, and Wayne, you and I, we talked about this before. There's a limitation to this because the people that I know who did this did not want to make their records public, but it was a family from Los Angeles, an older man. He was suffering what appeared to be a stroke. He comes to LHGV. They seek out a doctor because they want to have longer term care, and they are recommended to a doctor at NYU, Hospital A. It doesn't really matter what hospital it was. The doctor at Hospital A is ready to receive them. There is a bed, everything is ready to go, and all they are waiting for is the interfacility transfer. And they waited 3 hours for this. And I mean, what they said, and this is anecdotal, is that, there was someone on the staff in the emergency room that if I were you, I would just go grab a cab. Now, my family was just in NYU. I know that when you're being discharged, you wait for the ambulance to go home. It can take 3 hours to get that ambulance, but you're sitting in a hospital. I'm trying to understand in all of this, where are the snags? Like, you talk about calling the interfacility. So on the one hand, we've heard from Ritu, there's a question like, is there a reluctance to do interfacility transfer to another system? I know you're going to say that there isn't, but it should be interesting feedback for you to hear that someone has had experience otherwise. My question is more, you've described in great detail and very interesting and impressive this whole call system and your prioritization of emergencies and all that kind of stuff. Somewhere in the middle, there has to be a vehicle that takes someone from LHGV to whatever other hospital it is. Now, can that be a snag? And why is it a snag? Is it that there's a third party? And maybe I should shut up.
When you say vehicle, you're talking about the actual ambulance?
Yeah, so you're in the hospital, you have a serious medical condition, you're going to have to be admitted. You have a friend who is the greatest brain surgeon in New York City, and he is at Hospital A, which is not in your system. You have to get there fast, but
yeah, that's a great question. So earlier when I was talking about that auto launch feature, so in an example where somebody has a life-threatening brain bleed, when I call the transfer center, I'll tell them this is a tier 1 transfer, and oftentimes that ambulance will pull in even before I'm off the phone call. So sometimes, and other systems won't do this, but we'll actually hold our ambulance for 1 hour at the bedside, even if we're waiting for an accepting physician. And we'll tell the crew, don't go yet. We're trying to find out if their ICU has capacity. We're trying to find out, if the ICU doctor will accept this or the neurosurgeon will accept this. So other health systems most health systems won't even dispatch that crew until you have a receiving facility. And Dr. Berkowitz, do you want to talk a little bit about that? Layer some.
What I want to just ask is, I know of this instance where all of that, everything you described just didn't work, right? So it was a stroke patient, there was a hospital ready to receive him, but the interfacility transfer wasn't happening. So maybe you can share with us where snags might come up. How does that happen?
I can absolutely talk about how this works, how EMS gets dispatched. So just so you know, the median time from acceptance to getting an ambulance to LHGV to move them anywhere for a non auto launch or life-threatening call is about 75 minutes. it compares very favorably to many people, many others in the region. For an auto launch transport, meaning what Tucker described, what we do is a significant innovation. We've gotten numerous publications on it, poster presentations and whatnot within the EMS community. And we just published on actually how it reduces door in, door out time for stroke. That being said, without going into all the details about kind of how EMS and medical transportation is structured, it is not a first in, first out queue. So if someone is waiting for an ambulance and a sicker patient, someone calls from their house, maybe calls directly in, and every call into our dispatch center gets assigned a code based on a structured, internationally accepted system. If that patient happens to be a sicker patient, the ambulance, the closest of ambulance goes there, because it doesn't work like a comparable like a taxi or an Uber, because we have to take into account the patient's medical condition. So there are these outliers, and also I know historically, because I have had there's people will ask about these events, in a lot of cases where people will recount their episode, what we consider the ring time, what Tucker described, the time that our phone, we pull it off the phone system. It's integrated into our data center. We pull it off the phone system. That ring time is what we consider our time zero. And so a lot of times what is likely happening in these situations, based on my experience, is actually the ring time is not the time that the patient is thinking is the time zero. That's a separate complexity of looking at this data. Again, this is why we have a team to manage the data for us, to look at the phone call data, to look at the ambulance data, and also to look at our decision support system data.
So are you saying that a patient could be told we're calling an ambulance for you and actually the call isn't placed for a certain amount of time? Is that what you mean by a discrepancy in the ring time?
Right. So when we've investigated cases, we found that the recollection of when someone thought, so it may be whether it was however it was, sometimes people recollect that I got to the hospital, I was there 6 hours, and it took them 6 hours to get me to the next hospital. So the perception of what happened is challenging. We go by the ring time, and that's.
No, I understand that. I'm asking if are times when there's a delay in making the call. That
I don't think is the case, because we actually, not only do we have what we described, we actually have a way we actually have a tool that we've given all the doctors that they can literally through a secure chat can literally give us the information we need to begin moving things. So it's usually not on that end. Sometimes it is on the end of someone saying, "Hey, I spoke to my friend, and they're gonna, they want them over there." Usually, the bar is very low to get our team notified, and that works really well. What I'm saying is that the ring time, the time that we're called, we track this data really well.
Yeah.
And whenever we go to a non-ortho hospital, and we say, and they may say, they have the opportunity to say, we want to use another EMS agency. They can never get there as fast as we can. In fact, we routinely have to do other transports that other people that are kind of outside. So, which is fine. We have the biggest hospital-based EMS agency in the Northeast.
What you're describing is a perfect system that has got it down, that keeps flawless data, where an episode that was described to me could not happen. A guy bleeding on the brain has it. So I want to hear what it is. Where are the outliers? What kind of outlier data do you have? You've shared your median data or your mean data, I guess. Right. But the outlier cases are what interest me, because I know that they exist. Obviously, it's unlikely that you'll want to share them with us. And of course, we would love to have a lot of public here to share them, but it is an anecdotal thing that we have heard over the time. And the system that you're describing, it would never happen. And yet I know that it has happened. So can you share with me what happens in these outlier cases where someone does have bleeding on the brain and is trying to go to hospital A and has waited 3 hours for an ambulance?
I would actually love to investigate that case because, like I said, for a tier 1, our 90th percentile is about is about I think 45 to 50 minutes. And so we're talking about something that may be, I mean, yes, if it's a snowstorm or there's flooding and there's other things.
No, this was summer, right?
Right. But I would, I would love to, I would want to investigate that case. Because aside from that, we also, on the quality side, every transfer, and no transfer center in the US does this, every transfer we do, we send a survey to the doctor who's taking care of the patient and ask them, did we arrive in time? And, and if they say no, we have a full investigation. And I can guarantee you, if there's an intracranial hemorrhage with a 3-hour wait, I would have heard about it. So I haven't heard about it. So I'd love to, if you can share me details.
Well, the problem is that when I had this conversation with Wayne about this specific case, it just happens to be a friend of a friend. They didn't, obviously they had to be willing to sign away their privacy and they were not comfortable doing that. So the story ends as an anecdotal story.
Can we give them Dr. Berkowitz's contact information?
Can we what?
Give them Dr. Berkowitz's contact information?
They live in Los Angeles, and I think that they're sort of like done. I think they're like done. I'm happy that incident happened. I mean, an incident is in the past. I'm sorry. What were you saying?
We did review that case, but the patient did, specifically say that they did not want us to discuss the private details of that case. Sometimes I will say that patients will perceive that they were in the ER for 3 hours or 4 hours, and then when we actually pull the timeline, it's oftentimes 1 hour, 20 minutes. But sometimes in the heat of the moment, 1 hour can feel like 3 hours. And even though we're not allowed to discuss any of the details of that case, we are allowed to share positive feedback. And that case in particular, the family was so grateful for the care that we delivered. They actually physically came back 3 days after the ER visit, and they made a point to see the ER doctor and thank her in person. And she said, please, on behalf of my loved one, please, I want to thank you, thank your staff. You did an amazing job. And those type of stories really make our day. We're really grateful when we have a positive outcome and we made a difference in a patient's life.
They were very happy with the care that they got at the emergency room, and they felt that everyone was very kind to them. And it's really, it's so unfair that we're talking about this. We really can't. It's like he said, she said, but they were really unhappy with how long it took them to get to the other hospital. Really unhappy. Like obviously I was on the phone. This whole meeting came about because of that experience, because I was quite taken aback by it. I cannot. You might have data that completely goes against this. I can't really believe that it's all patient perception. But I don't think we can go much deeper than that because we have a limited amount of data.
Susanna, if I could make a comment, and I'm not referring at all to the case that the two of you are referring to, but you said earlier that you went to NYU's emergency department recently and you waited in the emergency department for 24 hours or so before you were able to get a bed. So what happens is
like that emergency room was like a freaking street party.
And that 24-hour time frame is very, very typical of what would happen in any emergency room. So when we transfer a patient, we try really hard to transfer you directly to the bed so that you don't have to go to the ER. We can get you to the ER real fast.
Yeah, I know. I think that, and again, we are here to talk about personal information. It was my parents who are quite old, and my dad was having some kidney issues. He went straight to NYU because he knew that at NYU, yes, it might take time for him to get a bed, but the physicians that were part of his team would be looking at his case immediately, and he would have immediate access to that. So I can foresee situations where, I had a kidney stone. I went to LHGV. The greatest thing in the world. They saw me in 20 minutes. It was fantastic. That's a perfect case for an emergency room. They gave me a fantastic shot of Toradol and I was home. my parents who knew that they were going to need, to be admitted, didn't even go to LHGV because they did not want to have that interruption, and the lack of it, and the lack of their team there. And I guess I mean, why would I even bother raising it? There is a question for me in the relationship that we have with LHGV about when someone should and shouldn't use the facility. So years ago, there was this like silly anecdote that went around in our neighborhood of someone who got a bee sting and they went to the emergency room at LHGV and they got this big hospital bill. Well, the moral of the story is don't go to the emergency room when you have a bee sting, go to urgent care, right? That's one side. The other side is, I think, like if you know you're having, if you know that your doctors are at hospital A and you know that you're having a problem that you've had before that's going to be treated by hospital A, just go straight to hospital A. So I'm trying to figure out sort of a consumer perspective of when you want to go to LHGV and when those interfacility snags can end up making things less efficient, I guess.
It's a great question, and there's not a simple answer. Literally last week, I was taking care of this 96-year-old gentleman brought in by his son, and he knew. He said, "I'm 90% sure my father's going to get admitted, and I know the process. I know I'm going to get transferred." But he said, "I so much prefer the peace and tranquility of your emergency department, even though it's going to require a second step. I don't want to wait in another ER. I'd rather start here, knowing it's even going to involve a transfer because the ER experience is so pleasant." So patients have different perspectives, and then we'll have other patients who don't want it to be fragmented. If they think they're going to get admitted, they'll go to a hospital with admitting privileges. So we really see both ends of the spectrum, to be quite honest. So it comes down to personal patient preference.
So I'm going to ask one more question, and I'll give it to Ryder. So if you go to the emergency room at LHGV, knowing that you're going to end up at hospital B, while you're in the emergency room, someone is evaluating you and giving you tests and all that kind of stuff. Is there communication or is there the possibility of communication between your physicians who are not at LHGV, not part of Lenox Hill, to have communication with the staff at LHGV, or is that really something that just gets packaged and then passed along?
No, I can tell you when I'm working shifts, I love it if I can speak to a patient's cardiologist or their primary care physician or urologist, because they'll provide really great details that'll help me, administer the right treatment. So whenever patients know their name of their doctor, sometimes they'll even have their cell phone and their contact lists. It actually makes my job much easier if I can speak to the physician. And they'll know their medical history, their medication. So we do encourage that if it's possible.
Okay, sorry, Ryder, I'm so sorry. Go ahead.
No apology necessary. I have a 4-part question. In the spirit of sharing our personal experiences, I will say I had a good experience in 2019. I came in referred by urgent care with stomach pain that was suspected to be appendicitis. It was. I was transferred to Lenox Hill where I had the appendectomy, made it pre-rupture. So I was happy. I don't know if I did the survey, but if I did, I'm sure I would have said a 5. But I'm recalling slide 13 and the monthly breakdown of time of door to departure time. And so my first 2 parts, 1 and 2 of my 4-part question are: 1, what does that trend line look like, earlier than just 2023? Like, how is that trending over years, 2021, 2022? Is it basically static, or are there increases or decreases? Part 2 is, clearly there's within door to departure, it seems like there's 2 parts. There's like treatment and then ring time. And I guess like within that overarching trend line, what does it look like between treatment time versus wait time? I think just those 2 pieces of information would help paint a fuller picture of the primary issue we're concerned with.
Yeah, it's a great question. So as far as the door to departure time, so the first thing we have to do is make the diagnosis, and the appendicitis example is a great one. So when I'm treating somebody with abdominal pain, if I'm going to get a CAT scan, I'll explain to the patient, you're going to have to drink this contrast. It's going to take about an hour and a half, 2 hours to work down your stomach. Then you're going to get a CAT scan. It'll take about an hour to get the official reading from the radiologist. So we might not have the diagnosis until the 4-hour mark. And then once we have the diagnosis, that's the ring time. So at that point, we will call the transfer center and initiate the transfer. Dr. Berkowitz, I see you have your hand up.
Just real quick, yeah. So, and I know you're asking for recent data, so I took a look at the data for September, October, we've actually now we recently added a little bit more. It's resources or actually unit hours, the better description, but now it's actually taking us faster to get an ambulance to LHDV than it is in many cases even to get a bed. Which is the traditional bottleneck. Now, of course, there are outliers, and most of my job is in studying the outliers, and we have a dedicated quality team for doing that. But we've actually the recent data is actually even better than it was before. When even though there are outliers, it was still based on, like I said, based on my knowledge from my peers in this industry, an exceptional performance.
And one thing I have to give Dr. Berkowitz credit for is, as we do get busier, we see our number of transfers go up. And a couple months ago, he said, I've noticed you're getting busier. We're following the data. We're going to actually shift another resource, another ambulance unit from one part of Queens to Manhattan to try to keep those numbers, those transit times down. So they really look at it pretty closely.
So the ambulances are all yours, or are they third party? Like, where do third parties come into all of this?
Yeah, so like I said, we are the largest hospital-based EMS agency in the Northeast. We do use third parties for sure. We in fact have people from third parties in our dispatch center that have their own seat, so we can use them and that they can offer resources. The reality of it is, and they're there because they want the business, to be frank.
Right.
And the reality is that they rarely can they help out. Ultimately, we end up having, we'll send ambulances all the way to Westchester, to Jersey, because there are patients who are really sick and no one can get to that patient. There's a lot more about the state of the ambulance industry. I would highly recommend you just start reading about it because it's fascinating and slightly depressing.
Yeah, I don't think that would be good for me.
Okay, so I'll do the third and fourth part. I appreciate the commentary, but I don't think I'm still interested in the answers to my first two questions about the monthly, the wait time by month for before 2023, so we can assess it over time. On slide 14, you talked about the rate of denial for transfers to non-Northwell facilities. That just, I'm like, 34.5%. Because that is so much higher than the 1% denial, I guess I wonder, is that a good enough status quo, or is that a problem to be solved where, is there something to learn about not requesting a certain category of transfers because we know that hospital A is not going to have beds for this kind of thing? Is there something to learn? Because I think ideally that should be much lower, not necessarily because they're taking all the transfers, but because, we're asking more in a way that has accounted for the likely denials, or maybe that is the best possible status quo.
Well, also the other question I would have is, are denials based on simple availability of facilities, or is there more reluctance to accept someone from your system? I mean, that is a huge discrepancy, right? 2% to 34%, right?
And it doesn't make sense.
And so is it that, right? And so everyone's got a certain, a limited number of beds. Is there more reluctance on different hospital systems to accept patients from other hospital systems, inter-system patient transfer? Is that still a sticking point? Because I remember that it was, when you first started out, I remember we used to talk a lot about how if you moved a patient from LHGV to hospital A that was not Lenox Hill, you often had to go through the emergency room or something like that, that it was that those inter-system transfers were sticky. And I was led to believe that during COVID, a lot of those walls broke down. I may be making this whole thing up. I don't have no idea what I'm talking about really, but what that discrepancy between 2% and 34%, what is that? Is that just more beds, or is that like, you know what, we're hospital A and we're going to first give our beds to hospital A beds, people in our system?
Sure. It's a great question, and we hate that 34.5% number as well. Sometimes a patient will say, can you transfer me to hospital X? And sometimes we'll take a deep breath, because we know oftentimes they don't have the bandwidth, that they'll have 20 admitted patients in their emergency room and they're waiting to go up, and now they're competing with our transfer. So there is oftentimes a supply and demand mismatch, and it really comes down to bed capacity. When we do get denied, the most common reason is they say we have no bed. And I gave my orthopedic example when I had the elderly patient with the hip fracture. She said, can you transfer me to hospital X? And we spoke to the transfer center, and they said, we're full. We would love to do the case, but we have other cases in the emergency room trying to go up. And then I called her second choice, same answer. The hospital had no inpatient beds. They said, if we did the surgery, we're not going to be able to put her into an inpatient bed. We're full. So then we ended up having to go with the third choice. So in New York State, over the past 2 decades, because of hospital closures and even just closures of inpatient units, the state as a whole has lost 20,000 inpatient hospital beds. And so it does oftentimes come down to bed capacity. Sometimes they'll give us other denial reasons, like every now and then a hospital will say, oh, we think you could handle that on your own. Or sometimes they will say it doesn't meet our criteria for acceptance. But by and large, it's oftentimes due to bed capacity. During the whole triple-demic, when the kids were had RSV infections, we had some sick babies, and they always go out of their way to accept a baby. But during that whole triple-demic RSV craze, NYU was full, Cornell was full. But they always try not to say no with kids, but because of the bed crunch, if you have a bad flu season or RSV or COVID, COVID was a glaring example where hospitals had to repurpose their operating rooms and turn them into inpatient units. Sometimes hospitals were turning their conference rooms into inpatient units. The bed capacity became really glaring during COVID.
But I'm going to guess that hospitals prioritize people in their own emergency rooms before
I really want to say something right there.
Yeah, go ahead.
I mean, it bothers me if Lenox Hill has beds. Maybe Lenox Hill is not the best hospital. I mean, that's the implication. Because you would think that.
Well, the other implication might be that Lenox Hill prioritizes people in its own emergency department.
I mean, there's something really pushy about those statistics.
Well, is it?
And the fact that some hospitals, and why does Lenox have beds? That is not a good thing if nobody else has beds.
No, so this is not really about, this is really a little bit more than about beds, because it really has to do with kind of what their processes are. There's a fair amount of heterogeneity, and Tucker did a great job with those boxes describing where the different bottlenecks can happen. So it's not really just about beds, because Lenox Hill honestly is frequently is at capacity. But they do find a way to make room for patients at Lenox Health Greenwich Village, because it's the same hospital. So
right. Exactly.
they think of LHCV as being an extension of Lenox Hill, and so these are their patients regardless.
So my parents who are in the emergency room at NYU were going to be prioritized for a bed before someone from Mount Sinai or LHGV.
Correct. Now this is not an isolated thing. There's actually a Greater New York Hospital Association work group. And they are putting resources to trying to improve the transfer process in the system. Occasionally, I do have to call the medical directors of other healthcare systems to say, hey, we can't do this. It's like sometimes there's a patient who just had a major surgery at a hospital, has a complication, and we're stuck kind of trying to figure out what to do. And those are the situations where it really gets escalated, and we kind of have to say that this can't be. I can say that on the Northwell side, that we never turned down a patient that was our recent surgical patient, which it might sound crazy to you that someone would even do that. I'm actually really proud that I know for a fact, and I can say that if someone's had surgery at one of our sites, we're going to find a way to take that patient, regardless of what's going of the bed status. If they're having surgery. I would love to say that's the same for everyone else, but I can tell you it's not.
But I'm going to guess that another reason a consumer might choose to go to a different hospital's emergency room is because they expect that they will be prioritized for a bed in that hospital in a way that someone coming from LHGV may not be. Fair to say, right? I mean, I don't know. NYU's, as I said, the emergency room, it really looked like a street party. There were so many people in there. And I'm going to guess that they, you know, when whoever's dealing out the beds is going to get rid of those, you know, put those people in beds before they come and accept.
Right. But then they're going to wait 24 hours in the ER.
Right.
Yes, that's the process that what you described sounds like the process they've decided to do.
Yeah, right. Sorry, go ahead.
My very last question, I promise, is what can we as a community board do to advocate for policies that would support better outcomes? This is good. It's good for us to just like learn, but should we be advocating for recovery of lost beds? And I think like maybe the most effective thing we can do, and I genuinely don't mean this humorously, is like advocate for congestion pricing to be implemented fully and quickly, because like traffic is legitimately a thing that is hurting patient outcomes. But like, what are the things that you want to see from the city council or state legislature or mayoral or gubernatorial administration? We have very limited influence, but it's non-zero. It's non-zero. So what can we be advocating that would help?
David, do you want to take this one?
Yeah, I mean, I can start. I think it's a really good question, and I think it's the value of partnership that we have together, and something I'd love to be able to follow up with you in person on as we think through it. I will tell you, I mean, a couple of the things that you brought up. Do I think increased bed capacity? The challenge with increased bed capacity is there's a cost associated with it, starting beds up, maintaining beds, reinvesting in beds, and as we all know, it becomes a very political issue also. So typically what we find in communities is once community leaders have gone through the process of taking beds offline, that's the painful political process. The idea of them coming back online, I mean, unfortunately, Greenwich Village is a perfect example of that. And so we're excited to be bringing some beds back. It's funny you bring up congestion pricing. Two sides to that coin. I mean, I certainly agree with you. I think the hope is that it aids with some of the traffic issues related to transport times. I will tell you, one of the things as a health system that we're concerned about is the effect on employment, is for folks who work in our institutions and come in every day and come in by car. The question that we grapple with quite a bit is, will this motivate some of the workforce to look for employment outside of Manhattan? And what effect does that have on the Manhattan institutions as a whole? And so two sides to that coin. We want less traffic, but we also want to make sure that we're still an employer of choice at the hospitals in and around Manhattan. So overarching theme here, this is one I would love to just give some thought to and come and sit down with you guys and talk through a bit, because again, I think the advocacy work that you do and the representation of the community, there are a lot of areas where what's best for the community is what's best for us. And so I think this can kick off a meaningful dialogue as we move forward if it's something you're open to. Of
course.
One of the things that I seem to get stuck on, because you are not just a standalone emergency room, but you are largely a standalone emergency room, is this question of intersystem transfer. As we're talking about beds and records and getting people on the phone and all that kind of stuff. And I guess to follow on Ryder's question, I think you mentioned that there's a working group working on this topic, unless I misunderstood that. That is something, is that an area that you think deserves some advocacy?
So,
I mean, how do you guys intermesh with the other hospital systems? Is it seamless or?
adversary.
I think there's opportunity for advocacy there. I think there's also opportunities for advocacy for EMS as well, just in general. It's, you know, there's been a bunch of legislative efforts over the past few years to right size the financial model for EMS. Both on the you know, on Medicaid and CMS, but that's you know, part of the ambulance availability issue is strictly kind of a supply, demand, and reimbursement straight out issue. It's really basic in economics. We do a great job. I'm really happy with what we do, but most EMS medical directors I know in the state are jealous, honestly, of what we have.
Got it. Emma, do you have anything you want to add?
This is great, thank you.
You work in healthcare. I would love to take you up at some point for an offline conversation about some areas that might be fruitful for us to look into going down the line. I hope that our challenging questions have not felt that we weren't grateful to have you here. And we really appreciate all of your sharing your expertise.
Absolutely.
If it's okay, I'll reach out to you and we'll schedule some time so that we could meet up and.
Yeah, that would be great. I also have a wacky question. So I'm looking, for example, at your leadership and I see Dr. Kwan is chief of cardiology. Where does cardiology reside at LHGV? It's not in the emergency room. So where is that happening?
Dr. Singh, do you want to take that one?
Yeah, so thanks for asking. I'm Dr. Kwan and I are the two cardiologists, so we love to talk about cardiology. So, you know, I oversee, I'm the chairman of cardiology at Lenox Health Hospital. I also have a regional role for all of the Western region cardiology for Northwell Health. And so you can understand what we are looking at in Manhattan. We're basically breaking Manhattan into a northern cardiology program and a southern cardiology program, with 34th Street as the unofficial demarcation line. Everything that exists in the northern program, and we were the number 10 ranked cardiology program in the country by US News and World Report about a month ago. So we really have a very robust and broad program in the north. It actually already exists in the southern program. So you're going to ask me, where is this? So on the outpatient side, we have an office just across the street from Lenox Health Greenwich Village, 7th Avenue. And that's where all of our subspecialties, whether it be heart failure, cardiogenetics, cardio-obstetrics, all of the things that really differentiate us from all of the other programs nationally already exist there. What we are going to do now is we're going to bolster what we are able to provide within the building of Lenox Health Greenwich Village. And that's what Tracy had alluded to the cardiac cath lab.
I see. So what you're saying is that when I hear chief of cardiology and you're in cardiology, you have outpatient doctors that are part of the Lenox of the Northwell system that are physically outside of the building now, but accessible to patients who seek them. So you wouldn't access them necessarily through the hospital when you're at the emergency room. You would access them as part of your healthcare team as outpatient physicians. And you're trying to bring more of those services into the hospital with your expansion of operating rooms and so on and so forth. Is that right?
That's correct. You'll have a full cardiology program that's available 24/7 within the building of Lenox Health Greenwich Village. That hospital, those cardiologists and nurse practitioners will be dedicated to the emergency room itself on the floor, as well as to the 8-bedded unit that's new, as well as to the procedural unit. So it'll be much more of what you think of as a traditional cardiology program. We do that at Lenox Hill. We have inpatient facilities, and then the majority of our outpatient work is not done in the hospital, even in the hospital buildings. It's done at an outpatient office.
Yeah, I can add a little bit. The cardiology service is expanded, in the downtown, and we will have a full-time cardiologist inside the Lenox Health Greenwich Village. So if in the emergency room need a cardiology consult, we can come down right away. Okay.
Okay, got it. That's great. Thank you very much. I don't think we have any other questions. Is there any other questions up there? Oh, we should go to the chat, Mark.
Okay.
Just see.
If they could take down the,
Oh, do you mind? Yeah, stop sharing your screen and we'll look at the chat and see if there's anything we have missed. Been in the emergency room. It was a very good environment. Not enough transport. Shame on you. Okay. Marianne Stewart. On many occasions, it has taken 5, 6, 7 hours to be transported from the ED to the LH hospitals for emergency patients. The charge nurse said there are 2 ambulances available. This is a 97-year-old heart. Even with the bed secured at LH patient, the patient said we should take a lift to the hospital, and he was a heart patient with a cardiologist. Not enough transport. Okay, so what this is in the chat, someone shared another anecdotal experience of having waited a tremendously long time to be transferred out of LHCV. So, I mean, it raises questions for me again about, you know, I appreciate and respect all the data about your mean times, but clearly there are these outlier cases, and
I would be happy to talk with anyone that wants to discuss their cases. I don't have a problem.
Let's do that. So the person who we probably have Marianne Stewart, right, as having signed up for this.
Right.
Okay. Marianne Stewart, I don't know if you're still here. I think you are. We're going to put you in touch with Jonathan Berkowitz at the hospital and see if you can get some answers that are pleasing to you, and then maybe we'll ask you to report them out to us. Gail Fox has a question. Gail, can you unmute yourself? There you go. Gail, can you hear us?
Yes, thank you so much. Many of my concerns have been addressed during this meeting, you know, about transfers. So that part I'll leave. And I do have a small list, and at the end of it, if there is someone who could be a designee that I could discuss it with, I would appreciate it. No, I'm glad that you're in our community. I'm encouraged to hear that in 2025, there will be roughly 4 hospital beds. So I do ask, once that is up and running, what is the next plan and how many more beds? But I'm very encouraged to hear that. Regarding the flu shots, just to let you know, there are some of us who need the flu block shot. We are allergic to eggs and cannot take a full egg infusion in the flu shot. So I would ask that next year you make that offering as well, unless in our offline conversation you tell me there are only 10 people in the world who need that. But I always have to hunt around for it. I don't know what your relationship is with some of the Northwell medical practices around here when I finish my litany, if anyone wants to address that. But I live near the practice at 22 West 15, and they're not taking new patients. I tried twice this year, and I don't understand that. But, you know, if there's a relationship, okay. Thank you for the donations to the Ukraine. Is there a plan afoot to donate medical supplies to Israel? And yes, I did see your fabulous Netflix series, very impressive. And I know how true. A friend insisted I watched it, and I have no regrets. It's really remarkable. Just happy that, you know, we have the presence and start of even more of a hospital than was taken away from us. And then lastly, I do come once a year for one outpatient test over to your facility at 13th and 7th. And when I make my annual appointment, I tell them, feel free to email me to confirm it or call me on my landline. I'm counting. I got 12 texts from that. I mean, that's fine. I new friend. It's a lot. And then they sent me pre-register But the one time I did that a few years ago, I still had to fill everything out when I got there, same as every other practice. And I'm very good on preventive care, so I just go a little early and fill in my form. So thank you for listening. Again, if there is anyone who could follow up after, and I guess, what is your relationship with the Northwell Medical Practice at 22 West 15?
Thanks for your questions, Gail. I really appreciate it. So I'll take a couple of your questions, I'll answer them, and then I think other members of the team will be able to answer some of the others. So I'll just start on confirmation about the inpatient beds. So we will be opening with 8 inpatient beds. And then we have a plan to increase that to 12 inpatient beds. And as of this point, we don't have a plan to increase any more than 12, but it will go from 8 to 12. So that was the answer on the inpatient beds. In terms of the relationship, we work very, very closely with all of the medical practices in the Northwell system, and particularly for us here at Lenox Health Greenwich Village in the downtown medical practices. And so that's our South Chelsea practice. I am happy to reach out to you to understand what it is you need and to work that out for you. So Wayne, I think, has your contact information. So I'll reach out to you tomorrow. I'm gonna actually hand over to it, unless you have any other questions regarding those issues, I'm gonna hand it to Dr. Berkowitz, who's actually very involved with the system's relief efforts and can answer that question for you.
Yeah, so Mr. Dowling is very committed to to doing good in this world, and just like with Ukraine, when he asked us to respond, and that led to the Ukraine program that we have, and I actually have a team member right now en route to deliver some ambulances and other supplies. We are also looking at our response to the crisis in Israel. And I can't go into like all the details because we're still honestly working out logistics. You can imagine the logistics of this is quite complicated. And we have folks actually talking to various aid groups, Ministry of Health. And actually, honestly, as we're talking right now, I'm seeing things pop up on my screen relating to testing for technology we're looking to develop. We have an internal team of developers and specialists who honestly volunteer their time to do things like this, to do some good with what we've built at the health system. I will also add, I think what you were mentioning regarding the multiple texts and the paperwork, that was also something you mentioned, correct?
Yeah, so she got a bunch of texts.
Yes, I did. But my friends calmed me down. They said it's probably a robot and artificial intelligence.
So
and
I
don't know what to do with text.
I totally hear you on that. And before I was a doctor, I was a computer programmer, and I sit on some of our IT committees. We're actually working on part of the Epic transformation, and our Salesforce transformation is actually to streamline how we interact with patients to make it easier to manage. I totally hear you on that. That is something that we have invested a lot of resources to make better. And we do want to make it seamless and unified for our patients, and as easy as possible. So totally hear you on that one. And it's something that we're working on and invested a lot in.
One other question she raised, which is really, it's a whole discussion, but she said it's very hard. It's hard to find a doctor. I find it hard to find a doctor everywhere. Is there a shortage of doctors? I'm serious.
So
I mean, we're here. I know people, whatever, physicians in NYU that said they have a panel of 2,000 patients, and then they won't take any new patients, and you can't get an appointment for 6 months. I mean, is there a shortage of primary care doctors?
I can probably address that. Can everybody hear me okay?
Yeah.
So yeah, I'm the chair of medicine at Western Region and Lenox Health. And yes, the answer is there's a big shortage of primary care physicians. We've made a robust effort to try to enhance the number of primary care physicians we have. So in the Western Region, which is largely Manhattan, but we also have hired some physicians in Brooklyn, as well as in Astoria, Queens. And so we've added 10 primary care physicians. Most of them are just starting about a month ago. So Ms. Fox, I think that we just hired 2 new physicians who are going to be practicing in Chelsea. So hopefully it should be the bottleneck to get care from a primary care physician should improve. And I can tell you we're actively recruiting as well. There are other specialties it's not as difficult to recruit for, but we're making a concerted effort, and we've actually made considerable improvement in the past 6 months or so. We actually have, for what it's worth, we've offered contracts to 3 other physicians just in the past couple of weeks, and we've had 1 person sign, but we're probably not going to start for about 9 months. So this is a big problem. It's a problem here, it's a problem across the country, but we're very mindful of that. We're making a concerted effort to try to address that.
Okay, and then Gail wanted just to know the flu block shot. Do you guys offer the flu block shot?
I'm gonna find out, because I know we do have the flu pods, but for folks with
we do not offer the flu block shot, but I'll find out from where
Okay.
comes. We offer the 65 plus vaccine. I know, Gail, that's different than the egg-free flu block shot, but I will find out.
All right, guys, it's 8:35. I'm mindful of everyone's time. If there are no other questions, and I have not neglected to see people in the chat, thank you very much for everything.
Thank you.
Thank you so much.
Thank you for having us. Really enjoyed this.
Thank you so much.
Thank you. Thank
Bye-bye.
We got business.
Yeah, let's have one discussion about this business. I mean, I know we don't have a quorum here, but, Ritu. Ritu, can you stay? I wanted just to discuss the question that was raised at the beginning of our meeting about this, about the retirees. And I want to know how you feel, because I have an opinion about it. So I want to know your opinion.
I think it's really complicated. By the way, I'm also in her category, and personally, I don't think this Medicare Advantage is what we should be doing.
Speak a little loudly so that Ivy can hear.
Okay. I am in sympathy, and so is Village Independent Democrats with this, she's saying, but I don't think our role here now. That's what I'm thinking.
Ryder?
I feel undereducated about it. I mean, I've read the articles about the legal fights, but I don't feel prepared to offer a position as the committee.
Emma?
I feel similarly.
Yeah, I feel like, I mean, this is a negotiation between, it's basically a labor negotiation. I'm not gonna get involved in that. And also there are all kinds of fiscal implications, like, as you asked, I mean, does the city need this money? I don't feel like it's our place to wade into that. With 2 parties pitted against each other, I have no idea who is the party.
Well, I
sympathize
what she's saying, but I don't think that's what we should be doing. I do know something.
Advocacy for this.
Yeah.
There is advocacy for this.
And
Yeah.
advocacy against the city council bill, including from some labor leaders who think it inappropriately gets involved in their negotiation powers.
So
and Brennan is not a good guy.
I don't even know who that is. There's my lack of expertise. So I would be inclined not to take this on for our committee. I agree, I sympathize with whatever, but I don't feel like we are in any position to be able to advocate for one side or the other. It's just too into the weeds. And thankfully, there are people who do this for a living who are engaged. And I think she said that the union, even though she's not technically a union member, they do contract negotiation and they are negotiating this and lobbying for this. I feel it's their place to do that, not ours.
Agreed.
Okay. Yeah, Susan, our chair.
Yeah, thank you. I want to thank everybody for showing restraint on this, because this is highly politically charged, and it's not an area that we ever deal with. And it's, I don't think that we can contribute anything of benefit, but we could be hurting ourselves in terms of the work that we do and maintaining our identity as being apolitical.
Yes, and I
really
also
very important.
I tend to hate to enter into advocating for things that have serious fiscal complications. I mean, we do that. We do, ask for things that require money. But, I always worry because budgets are zero-sum games. If you want more arts, there's less school. If you want more school, there's less garbage. I mean, it's not like, you know.
But when we wade into something, it's because there's an underlying activity that we engage in for the benefit of the community.
Yes, and this,
if we're involved in assisting with certain types of services, or we hear certain types of applications, and then we weigh in on legislation, it's tied to it. It's a logical outgrowth. This is coming to us with absolutely none of that connection.
right, it's a citywide issue, as she herself said. So it's citywide, number one, it's a money, not right, okay. Thank you. And it's in litigation, right, okay, just a few reasons why. But I'm glad that we heard her and good.
A helpful example of like where scope falls. Anyways, I just appreciate it. So
Yes, I think.
your thoughts and your thoughts.
I think it is I think it is beyond the scope of what we do.
Illustration.
All right, thanks.
Thank you.
For hanging around.
Oh, I'm so glad I heard all of this, Lenox Hill stuff. I think it's really good news for us.
That is good news, but are we recording?
We're still, I can stop right now.
Yeah, can you stop recording?
All right, so we're signing off the meeting.
Uh,
Meeting adjourned.
the meeting, Susan, no, well,
No, we can talk about, you can